right. I am showing 1 o'clock Central Standard Time. Thank you for joining us today. Thank you for joining us for this edition of the South Central Telehealth Resource Center's Telehealth Roundup webinar series. We created this series as a way to create conversations about current goings-ons within telehealth, within the telehealth world, technology-wise, policy-wise, everything and anything related to telehealth. So I'm happy to introduce our guest presenter today, Miss Bonnie Britton, who I will introduce fully in a second. I'd like to go over the consortium and the telehealth resource centers. So before I do that, um, just a little bit about who we are and a couple of housekeeping. I'm gonna launch a poll here to see how familiar our attendees are with telehealth. If you would go ahead and fill that in for me. This session is being recorded. You can find it on our website at learntelehealth.org in just a few days. So if you missed something or you would like to share it, feel free to check out our website there. So poll results are coming in. A little bit of an intro for me. My name is Joe Schaffner. I'm the Assistant Director of Outreach for the South Central Telehealth Resource Center, located with the Institute for Digital Health and Innovation at the University of Arkansas for Medical Sciences, located in Little Rock, Arkansas. And so the South Central Telehealth Resource Center is located in red here on the map. We represent 3 states, Arkansas, Tennessee, and Mississippi. We are one of 12 regionally based telehealth resource centers, and there are 2 national resource centers. The Center for Connected Health Policy, which is our go-to place for all things policy related regulations. They track state, federal. Right now they have great, and here's the results of the polling there. So we're about middle of the road. So the Center for Connected Health Policy tracks all the policy related issues regarding telehealth, and they have really good resources right now if you want to check out their website on COVID-19 related policy as it relates to the public health emergency. And then the other national telehealth resource center is the Telehealth Technology Assessment Center, which is our go-to place for all things technology related. They have workshops, they have product reviews, great place to learn about the technology side of things. Now, we just created this nifty little video to give you an overview of the National Consortium of Telehealth Resource Centers and what we do. So I'd like to share that with you right now.
The National Consortium of Telehealth Resource Centers, NCTRC, is structured as a collaborative of 12 regional and 2 national telehealth resource centers, TRCs, funded individually through cooperative agreements from the Health Resources and Services Administration, HRSA, Office for the Advancement of Telehealth, OAT, and the Federal Office of Rural Health Policy, FORP. Working collaboratively under the NCTRC, all 14 TRCs are committed to implementing telehealth programs for rural and underserved communities across the United States of America. The NCTRC also supports the U.S. territories of Guam and American Samoa, the Commonwealth of the Northern Mariana Islands, and the freely associated states of the Republic of Palau, the Republic of the Marshall Islands, and the Federated States of Micronesia. Through telehealth and digitized healthcare, the NCTRC aims to increase accessibility to healthcare in hard-to-reach areas for rural and underserved patients. The NCTRC accomplishes this by assisting healthcare providers, clinics, hospitals, and more to implement telehealth programs that best fit their needs and overcome common telehealth barriers such as billing, reimbursement, and Medicaid policy barriers. All 14 TRCs serve as a gateway into telehealth by providing expert technical assistance, training, and resources to everyone. TRCs often host educational conferences and webinar events to educate folks in specific telehealth areas to strengthen telehealth connections and expanding opportunities across the nation. TRCs are committed to ensuring that everyone has access to safe, effective, and appropriate care, when and where they need it, enabling the system to do better for more people. Most rural and underserved areas are often neglected in terms of easily accessible healthcare services. Without accessible healthcare, some patients are prone to putting their health at risk. The NCTRC helps healthcare providers and systems overcome telehealth barriers. If you have an interest in telehealth, reach out to your regional or national TRC. Healthcare providers working in all types of health environments can now provide services to patients, regardless of where they live. Jane works as a healthcare provider in a clinic. She has been looking to get some training in palliative care so she can help her patients that live in rural areas and don't have access to health services. With the assistance from the TRCs, Jane is now able to provide palliative care to those in need. She attended several online events and webinars held by the TRCs, which provided her with the necessary knowledge and understanding. Working as a healthcare professional, Bill has always been a strong advocate for behavioral health. He wants to reach a wider audience and help those in need. With the help of the NCTRC, Bill was able to learn by connecting with his TRC and their educational resources. Now, he can easily provide services to those who are in far-reached areas without any difficulty. The TRCs also provided technical assistance, helping Bill understand billing and reimbursement issues. Jane and Bill aren't the only ones. Their hospital is now adapting telehealth as an integral part of their healthcare delivery system, reaching people even in geographically challenged areas and providing their services to the best of their ability, all with the help of the TRCs. The NCTRC is working to change the way the world thinks about healthcare, one connection at a time. Fill out the NCTRC contact form to get in touch with the TRC and step into the world of digitized healthcare.
All right, so that's us in a nutshell. Moving on.
Transmitted in the following ways. Originally, and there still is some devices that work over the Plato telephone system, so a telephone line in the patient's home. It can also transmit over the internet as well as cellular. But what's super important to understand when you're trying to stand up an RPM program and you're looking at device vendors is how do they transmit data? If it is cellular, for an example, and the only cellular transmission that they can provide is by Verizon, and in your location of where you're located, you don't have a broad Verizon transmission availability, you have more AT&T or T-Mobile, then you don't want to select a vendor that's going to transmit via one cellular connection that does not work well in your area. Let me give you an example. Appalachian Regional Health in mountainous Eastern Kentucky, when they did an assessment of their patient population, they found that a lot of their patients still had a Plato telephone system and didn't have cellular connectivity. They also found that a large majority of their patients did not have internet for connectivity. They also found that depending on what part of the mountain and on what side of the mountain you're located on, that data was transmitted cellularly from Verizon, AT&T, and T-Mobile. So they needed to find a device vendor that could transmit data via phone line, internet, and Verizon, AT&T, and T-Mobile. So that's super important because if you select the wrong transmission option that doesn't work in your area, then your program's doomed from the very beginning. So that's the most important. The patient may not be able to learn how to use the devices. Most patients can learn. The most difficult is learning how to put on a blood pressure cuff correctly. If the patient can't learn to do it, is there a caregiver present? Is there an aide who comes in the home X number of days a week? Is there a next door neighbor? Is there a child? Is there someone else that can help with them? And then if they're unwilling or unable to communicate with a healthcare team, What I mean by that is a lot of patients have an Obama phone. They have 20 minutes of data time during that month. And we found that a lot of patients do not want to use their 20 minutes communicating to the healthcare team, which is sad, but it is also true. And then in an unsafe environment, meaning, are there holes in the roof where the technology could get water damage? Are the electrical outlets falling out of the wall and are they unsafe? Is the home infested with cockroaches? Because cockroaches love those warm little peripherals. So, do they not have a level surface to be able to place a scale on? So again, the point of this slide is really include everyone that can be included and opt out by your exclusion criteria. So the really critical things when you're talking about are putting together an RPM program, most organizations focus initially on the technology. I put the technology at the bottom, not saying it's the least important, but I think it's important to go through these other steps to then determine the type of technology that you're going to need. So the first thing you're going to do is identify those use cases. If you're looking at RPM from a clinical perspective, are you going to focus on patients with hypertension? Are you going to focus on patients with hemoglobin A1Cs that are greater than 7 or greater than 9? Are you going to focus on uncontrolled heart failure or COPD? What are the clinical criteria that you would like to evaluate over time and see the trending of the weights or the trending of the hemoglobin A1Cs and the blood glucoses, to go down, that the blood pressures over time are going down, etc. From a financial patient selection criteria, depending on the organization you're in, a lot of organizations have implemented this to reduce their 30-day and 90-day hospital readmissions, to decrease ED usage. And then a lot of organizations utilize it for self-pay population, because the self-pay populations are the greatest population that are write-offs for health systems, because they can't collect because the patients are self-pay. So these are just some of the things that you would want to think about. I always like to see a balanced approach because I'm a nurse. Of course, there has to be a financial return on investment for the organization to continue the program. If you are a clinic, another financial patient selection criteria would be to increase your CMS reimbursement, that we're going to be doing an RPM reimbursement presentation in December that will delve into all the components of that reimbursement and how to actually bill CMS for reimbursement of the RPM CPT codes. So this is just another example of how hospitals and health systems use it to reduce their admission, their ED costs, and to lower those overall healthcare costs, whether that is self-pay patients or Medicare. What I've found over time is Medicaid, those hospitals tend to have a better margin with Medicaid dollars than they do with Medicare, but that varies state to state. If you're a home health agency, now there's that emphasis in reducing your 30-day readmission. And then the other thing I didn't list here is to decrease the number of your in-home skilled visits. So let's say that an in-home skilled visit costs $130. If you can, and your devices, let's say for ease of math, are $50 per patient per month, the monitoring of that is, let's say, $50 per patient per month. So your total per patient per month cost will be $100. If you decrease one skilled visit in a 60-day episode of care, you've covered the cost for your RPM. So that's, and really home health is where remote patient monitoring began, to decrease windshield time for nurses who were taking care of home health patients. Starting January 1st of this year, and now home health agencies can include the total cost, their annual cost for remote patient monitoring in their annual cost report. For some home health agencies, that's a big deal because they haven't maxed out on their annual cost report. For other home health agencies who already have maxed out, it's not as great an incentive to provide, but reducing the number of in-home nursing visits, as long as you stay above the LUPA level, is a financial win for home health agencies. Nursing homes now have a focus to decrease 30-day hospital readmissions and reduce ambulance transfers. So we're seeing a lot more patients that are going into the nursing home on the skilled side of nursing homes, implementing remote patient monitoring to achieve these two objectives. And then the patient, a lot of times will go home with the technology to continue to increase that patient's engagement in their care. And then, as I previously mentioned, for primary care provider clinics, or it could be specialty clinics, it depends upon who is a primary provider for that patient. If I'm a diabetic, that's my only condition, and my endocrinologist is responsible for my diabetic care, then it would be an endocrinologist who could bill for CMS reimbursement for the 4 CPT codes. If my primary care provider is my local PCP, then they can bill for remote patient monitoring. Also, and the greatest financial gain for primary care provider clinics is an increase in your macro MIP scores, which are your quality scores, which will result in an increase in reimbursement at the end of the year. Next thing is super important is that how do you develop your conceptual model? What I'm talking about is when you implement remote patient monitoring, there's really two components to that. One is the devices and the other is the actual management, taking care of the patient. So what I'm going to describe to you, there is no right or wrong way to develop your conceptual model. It totally depends upon your internal resources and your capabilities. So when you think about device management and you order devices, those devices come in, someone has to do inventory, then they have to be stored. Then when a patient's identified, someone has to pull those devices and get those devices ready to go out into a patient home. And then when the devices, the patient's discharged from the program, someone has to pick up those devices, they have to get back to the office somehow, and somebody needs to clean, refurbish, and restock those devices. So that's something to think about. Do you have the resources, human resources, and the space to be able to handle inventory coming in and then pulling and managing, cleaning, all of those things? If you don't have those resources, then most organizations will outsource that to the device vendor. So that the device vendor maintains the inventory, they store it. When a patient needs it, they ship it. So they pull it off their shelf, they ship it directly to the patient. And I'm going to talk about installation in a minute. And then when the devices are completed, patient is completed in the program, those devices are shipped back to the vendor to refurbish and clean those devices and store them, waiting for that next patient. So think about that. This can be a downfall for an organization. We recently worked with an organization that decided that they wanted all of this device management and the installations to be conducted by their DME company. What they did not do is they did not provide the DME company with any money or resources to be able to provide these services. Therefore, the DME company never saw it as a priority for them, and the program from a device management perspective failed miserably. So let's talk about installation options. The best practice that's out there is in-home installation, training the patients, going in, installing the devices, demonstrating how to use the devices, have the patient return, demonstrate, collecting those the data from those devices, and then competency validating a patient. The next best is in clinic or in hospital training. So if you're a clinic and you want to implement this, the patient, when they come into their clinic appointment, you can train them then, or if you're a hospital, you can train them while they're in the hospital and send the equipment home with them. Or your other option is, as I previously discussed, outsource that installation to the device vendor. Then you need to think about how are you going to monitor these patients. So remote patient monitoring, the gold standard is patients monitor Monday through Friday. And there's rationales for that. If we have time, we can discuss it. Or if people have questions about that, we can discuss it. So do you have the internal resources to be able to monitor? One nurse can monitor up to 100 patients. Once that nurse becomes very comfortable with doing that. So do you have the internal resources to do that? Most organizations that do their own monitoring, they do so because they have an established trusted relationship already with that patient or that population. They're unwilling for a third party to access their EHR. But it's super, super important that you have dedicated staff with experience outside the four walls of a health environment. And what I'm talking about there was a recent article that was published on the downfall of remote patient monitoring. And I know this from 23 years of experience. If you don't have dedicated staff to this and you just add this responsibility across several staff and not lighten any of their load, it's going to fail because it's never going to be a priority for those nurses. The other thing that we found is that if you have, let's say, it's a post heart failure discharge program, and you have either intensive care nurses or intermediate care step down nurses that are monitoring the data, that data is much different than being in the hospital looking at data on a critically ill patient. Remote patient monitoring is about looking at trended data over time and trying to help patients make a correlation between what they did or did not do yesterday and how they feel today. So it's super important that if you have dedicated staff, that they need to have some experience outside of the hospital, certainly, and outside the clinic, if at all possible. Other organizations outsource that monitoring. One of the main reasons is if they're in a state with a union and it's extremely expensive or very difficult to hire an RN. Also, organizations don't want the additional FTEs and all of the expenses that surround that. But one of the things that outsourcing the monitoring is essential for and is a benefit for your organization is that your staff or your physicians are only going to receive validated actual data when there needs to be a medical intervention. And it allows the RN to work at the top of their license. And it also removes the need for you to provide non-clinical services such as alert validation. And this will make a little bit better sense in just a minute. Instructing the patient on how to use the devices. If the patient doesn't do their reading, having to call them to find out why they didn't do their reading, encourage them to conduct those readings. And if they did do the readings, then providing tier 1 troubleshooting. So this next slide kind of demonstrates that. So this was a health plan, and this is 18 patients. For 3 months, those 18 patients had a total of 717 alerts, meaning their data was outside either high or low from the parameters that the providers had placed for that data set. Out of all of those, so that 717 alerts, someone has to call that patient and validate that the alert is correct, conduct a nursing assessment, provide education, and then, if needed, If the RN believes the patient may need a medical intervention, then they would escalate that up to either the customer or to the patient's provider, depending on how that conceptual model is designed. So of those 717 alerts that the organization did not have to do anything about, all they had to respond to was 16 alerts that needed medical outreach. So it averted 701 alerts from that customer. So again, there's no one way is right or one way is wrong. It all depends upon the resources you have in your organization. The next thing is that's super important is creating a patient identification, enrollment, and referral workflow. And the things that I would go through with developing this is who's the best person in your organization to identify, or persons to identify the patients. And then once the patient is identified, who's the best person to either meet or call with that patient to explain the program and obtain verbal consent. Who is the best person then to enter the information into the software and refer that patient? And then who is the best person to identify devices that are needed? It is critical that you understand your current workflow and integrate our remote patient monitoring workflows into your current practice. And so with keeping that in mind, then these are the questions you're going to ask to develop your referral. So it may be, this is hypothetical, I'm making this up. If it's a hospital-based program, the best person to identify the patient may be the discharge planner. It may be best for that discharge planner to meet the patient in the hospital, explain the program, give that off to a clerical person who would then do the referral of the software, enter the patient information, and then that discharge planner will be the person that says, okay, this patient's going to need a blood pressure, heart rate meter, and a scale. If you're in a clinic, the best person to identify the patient may be the providers. It may be the providers' nurses. So you need to go through based on your organization and answer these questions to be able to capture a true workflow for remote patient monitoring. And then the next step is the patient installation education workflow. Who is going to install the devices? If it is going to be, let's say, a DME company, or if it's going to be your biomed staff, or if it's going to be a CNA, if it's going to be the home health agency nurse, or a technical person that's going to do the installation. If it's done an in-home installation, there you will need a written authorization form, which I have examples that I'm welcome to share. They need to go in and provide an educational sheet on proper data collection techniques. And that's not just on, stand on the scale or place your finger in this pulse ox. It's more of those things of before you weigh, you empty your bladder, you weigh the same time of the day with the same amount of clothes on. After you take your hypertensive meds, you wait an hour, you sit in your easy chair, you rest 10 minutes, and you take two back-to-back blood pressures. And then someone is then going to demonstrate how to use those devices. The patient needs to collect 2 sets of readings per device. And we recommend 2 because a lot of these patients are elderly, and they need to have that confidence that they can do that, and then have the patient sign a competency validation form that can be maintained in your records so that the Joint Commission or other accreditation agency comes in and says, well, how do we know this patient's been trained? You have a document to demonstrate that. So let's say that the devices are going to be shipped to the patient's home. So that's a little bit more difficult to get a written authorization. And during COVID, you don't have to. You can just get a verbal consent. Any remote patient monitoring program that is not going to be billing CMS, there is no requirement for a verbal order or a written consent. manufacturer should provide in the box with the devices, the educational sheet, and then they need to provide remote um, support to help the patient install those devices and collect readings. It can be done. It takes more time because you've got to have the time for shipping and all of that, and then calling and catching the patient there. But it certainly can happen. It has been happening a lot during COVID-19 when patients don't want you in their home, and folks don't want to go into patients' homes either. But the best practice is inpatient installation if possible. So when the registered nurse who is monitoring the patient, so basically what happens is you're going to monitor the patient's data Monday through Friday. Each data set has a high and a low alert that is set by the organization, either their chief medical officer or the physicians. And any patient that has a high or low alarm, which is an alert, you have to call that patient and validate the accuracy of the alert. Mrs. Jones, I see your blood pressure's up. Did you take your hypertensive medicine? No, I forgot to take those. Well, let's go over what's super important. You need to take your medication every day. You need to wait an hour. You need to sit and rest. Why don't you go ahead after we hang up and take your medication, wait an hour, sit in your easy chair, retake that. Or the patient may go, oh, well, that wasn't my blood pressure. My son came over and he checked his blood pressure. So what you're trying to do here is to validate, are the alerts, A, the patient's, and B, were they collected accurately? If the alert is not accurate, then you have to instruct the patient on device technique and instruct them to recheck their readings. So everything basically on this slide is a non-RN functionality. Most RNs do provide it so that the patient's only called once, because let's say the alert is accurate, then an RN needs to conduct a nursing assessment, just like you would at a bedside, except for you don't have a stethoscope. We call it, utilize a C-field change methodology. And what I mean by that is the patients can see their data. You help them articulate how they feel and help them make a correlation between what they did and didn't do yesterday and how they feel today. And that's when you start seeing long-term behavior change. Provide patient education. And I always recommend patient education based on the symptoms the patient's having. So if their weight's up because they ate Chinese food, then I would really focus on nutrition during that educational assessment. Then once all of that is done, if the registered nurse believes that the patient may need a medical intervention, just like at the bedside, you would contact the provider. Here, you would escalate that useful, actionable data up to the patient's primary care provider for them to make a determination if the patient needs a medical intervention. And then you document that encounter. De-installation workflow, how long are you going to monitor the patients? If you're a home health agency, it may be just the episode of care. If it is a post-discharge hospital program, it may be 90 days, because researchers found it takes about 78 days to make long-term behavior change. If you're a primary care provider clinic or a rural clinic, then you may have that patient on indefinitely. Or because the condition they have is not going to be going away, and you can implement the program and have ongoing CMS reimbursement. Then it's super important to have, whether you insource or outsource the monitoring, to have clinical calls or huddles with your team to discuss discharge from the program and your discharge criteria. Have they met their clinical goals? Are they adherent? And then you've got to decide, how are we going to retrieve those devices and refurbish it? Will that be outsourced to the vendor? Are you going to do it yourself? Is the patient going to bring it back to the clinic, etc.? So I know we're getting close in time. I'm going to leave time for questions. Super important to talk about in the very first conversations as you're determining your use cases and your selection criteria. how are you going to demonstrate a return on investment? Who's going to collect the data? What data needs to be collected? What is the time frame for collecting that data? What is the evaluation plan? You have to have a commitment from your CFO that that the evaluation plan and the data collection that you determine is something that the CFO and their team is committed to being able to pull that data to demonstrate that financial return on investment. So technology, I always, everybody looks at the bells and the whistles of technology, but basically everything that's out there, you want to make sure it's FDA cleared device. And basically all of the devices, every BP and heart rate meter does the same thing. All glucometers do the same thing. So each of the devices do the same thing across the platform. So for me, the things that I recommend people looking at, and number one is the software platform. How easy is it to use? Are there automatic timers to track time for reimbursement? Are there days of data that tracking for reimbursement purposes? Does it have the reports that you need to be able to demonstrate your return on investment? How easy is the devices to use? What is the cost of those devices? Then probably the most important, and I should have it up at the top, is your transmission options. If you only have Verizon in your area, you can't select a vendor that just transmits via AT&T. And all of them are going to tell you they transmit cellular, but you need to know which cellular companies to make sure that you don't run into that transmission option issue, because it can be a huge issue. Weight scales, pretty much a weight scale is a weight scale. What I look for is that the patient just stands on the scale. They don't have to press a button, that there is a verbal readout of the weight and says your weight is, and then you may step off the scale. To me, the broader the base of the scale, the better, because it's particularly difficult for unstable patients and obese patients to stand on a smaller base scale. Blood pressure and heart rate monitor, they basically all do the exact same thing. Again, it's looking at the ease of use and making sure that they have the cuff sizes that are going to meet your patient population's needs. This is an example of a glucose meter, and if you can see, it has an embedded cellular chip. And so this does not require anything to transmit the data other than a cellular signal. So this is an example of a cellular glucose meter. Pulse oximeter, really big difference between pulse oxes is it battery operated or is it plugged in for power? Okay, so we've got about 12 minutes. I'm going to stop and open it up for questions, because I'm sure you guys got questions, because I talked a lot in a little amount of time.
Bonnie, thank you so much. That's great. A lot of info to cover there. And so while everyone is thinking about their questions, oh, we got one here. Returning equipment and cleaning. What is the criteria in the sense if it is a glucometer, it involves blood? Is it returnable?
The glucometers can be returned. Some vendors are going to tell you no. Some vendors are going to tell you yes. The big key is cleaning and wiping them down according to the device vendor's recommendations. Those cellular ones you saw, that vendor does not recommend glucometers be utilized in between patients. The majority don't, but some do. But you have to go clean those devices based on the manufacturer's recommendations in their manual.
Okay. We have another one here. For non-self-pay, are you seeing CMS reimbursing for remote patient monitors?
For non-self-pay?
For non-self-pay, are you seeing CMS reimbursing for RPMs?
So if the patient has Medicare,
Yes.
then CMS is reimbursing for remote patient monitoring. And there's 4 codes that we're going to cover in great detail in December.
Okay. And speaking of codes, for those billing under CMS CPT codes for remote patient monitoring, can health coaches provide the service component pieces, specifically 99457 and 99458? I noticed you
Um,
mentioned nurses today, but some third-party vendors use health coaches.
well, here's it, CMS doesn't say who has to do it. I always put on the hat of making it as simple as possible for the providers, because we all know if you don't make it simple for the medical providers, they're not going to participate. So the only issue with health coaches is, or an LPN or a CNA or MA, is they can call that patient and they can validate the alert, but they can't conduct a nursing assessment and they can't initiate education. They can, yes, coach that patient, but what they're going to be doing is escalating information up to a provider who is then going to have to reach out and do an assessment of that patient. So, yes, there are companies that are providing services that way, and there's nothing wrong doing it that way, but it shifts the burden back to the primary care provider of the patient.
Okay. We have another question here about Medicaid. I know it varies from state to state. How many states cover remote patient monitoring?
I think it's like 27. But if you go to the National Telehealth Resource Center website, you can find that entire list.
Okay. Yeah, so that would be the website at the beginning when we were talking about the National Consortium, the COVID related information, as well as the state by state breakdown of telehealth policies and coverages. And they break it down by Medicare, Medicaid, and private payers. So it's a valuable resource. I'll put the website in the chat box. I'm also going to put our survey in the chat box while we're thinking about more questions. Please click on that link, copy and paste it, do it later, but we're looking for your feedback on if you've utilized the TRCs, how you feel about TRCs, and we'll use this information to improve our processes. So please look in the chat box, take that survey, let us know what you think. And so right now I'm going to go to the Center for Connected Health Policy and get that website and throw it up there. Thank you, Bonnie.
No other questions?
Not right now, as nope, I put the survey again. Hold on.
And I'm gonna share.
There we go. So the last link I put up there is the Center for Connected Health Policy there. Yep, there's
Yep.
Bonnie's contact info. I'll put my email in the chat box as well if you have any questions. And hey, we're here to help you with technical assistance. We also help people find funding for certification, for training, for education. So if you're interested in expanding your telehealth knowledge, shoot me an email and let's get that conversation going. All right. So now you have our contact information. Bonnie said feel free to call her in the middle of the night.
Sure. I'd
No,
love for you to reach out if you've got any questions or thoughts.
yeah, well, Bonnie, thank you so much. Again, this recording will be on our website here shortly. So if you'd like to revisit, if you'd like to share, feel free to do so. Bonnie Britton, thank you so much for your knowledge and expertise, being an expert in the field and sharing your time and talents here today with us.
Well, thank you so much for the opportunity. Thanks, everyone.
All right, stay safe. Have a good day.
All right. Bye-bye.